After vulvar, vaginal, cervical, and uterine cancer, now we come to the ovarian cancer. Ovarian cancer accounts for around 25 to 30% of all gynecological malignancy with highest mortality. Clinical challenges that 70% of these cancers present at an advanced stage, stage 3 or 4. Ovarian cancers show histological diversity because the ovary arises from pluripotent cells that can differentiate into various tissue types, including epithelial, germ cell, and sex cord stromal cells, leading to a wide range of tumor subtypes. There are two etiological models hypothesized for occurrence of ovarian tumor. The traditional one is the incessant ovulation theory. That means that repeated ovulation causes surface damage to the ovary, leading to DNA mutation over time, which causes cancer. The newer hypothesis is fallopian tube theory. According to this, many high-grade serous cancers originate in the fallopian tube and then spread to the ovary. This theory gets support by the presence of precursor lesions like STIC and SCOUT. STIC means serous tubal intraepithelial carcinoma, while SCOUT stands for secretory cell outgrowth. Now, I want you to sit tight and understand this concept very carefully. The ovary is basically made up of three kinds of cells. Outer layer of epithelium, inside filled with stroma, which is studded with the unique germ cells. The epithelial ovarian cells have the potential to undergo metaplasia. Metaplasia means when one cell type changes to other. Epithelial cells of ovary can undergo this metaplasia based on their memory that once they have originated from the Mullerian cells. That means they can change to cell types of fallopian tube, cervix, endometrium, and also gut and bladder because they come initially from the coelomic epithelium, which makes the gut, and develop alongside the Wolffian system, which makes the urinary tract. These epithelial cells of ovary, if they change into fallopian tube kind of cells, they make the serous tumor. If they convert into cervix or GI kind of cells, they make the mucinous kind of tumor. Endometrioid, when they become like endometrium, and clear cell, when they specifically develop into secretory kind of endometrium. And when they become bladder-like epithelium, that is the transitional epithelium type, it is called transitional cell tumor or more commonly the Brenner's tumor. Second is the ovarian stroma. Stroma of the ovary has two components: sex cord cells, which support and nourish the developing eggs, and the stromal cells, which make the connective tissue framework to hold everything together. Both these originate from the genital ridge during embryogenesis. Every cell in here has multipotency as they can differentiate into sex cord cells or stromal cells. When these cells go haywire, with their multipotency character, they form a tumor. If they become like ovarian follicle and start secreting estrogen, they become granulosa cell tumor. When they transform into those follicular cells that produce abnormal amount of androgen, they are called theca cell tumor. Transformation into testes-like cells produce androgen and make Sertoli or leading cell tumors. If the cell cluster takes the direction of fibroblast, it becomes a fibroma. If it is clear till now, let's move on to the third cell type, which is germ cell or the oocytes. Germ cells are totipotent. That means, as you can imagine, They can grow into any body cell or even the placental tissue. If the tumor cells become like primitive germ cells and remain undifferentiated, they form dysgerminoma. If they become like early embryonic gut and start producing alpha fetoprotein, they are called yolk sac tumor. If they start developing like the inner cell mass, they are called embryonal cell carcinoma. And by chance, if they become like placenta and start producing HCG, it is called choriocarcinoma. And teratoma means when all three germ layers, that are ectoderm, mesoderm, and endoderm, start developing in the tumor. After understanding this complicated pathogenesis of ovarian tumors, let me simplify it for you. In real life, whenever you see an ovarian cancer, 90% of the times it is going to be an epithelial cell cancer. For this very reason, we will now focus on the epithelial ovarian cancer. Epithelial ovarian cancer is also known as silent killer because it presents with no specific symptoms, just like gastritis, abdominal distension, bloating, early satiety, post-meal distension, sometimes urinary symptoms and bowel symptoms too. Characteristic finding in this tumor is an irregular, solid cystic abdominopelvic mass with ascites. For the diagnostic workup of ovarian cancer, you must understand 4 points. First, if you want to differentiate whether it is a benign mass or malignant, the investigation of choice is transvaginal sonography, or if it is an abdominal mass, abdominal plus transvaginal sonography. In cases of confusion, MRI helps. To find out its extent or spread, a CT scan, which is a CAP study, that means chest, abdomen, and pelvic CT scan, is done. Confirmation and the pathological diagnosis is made by the final surgical specimen. But sometimes in advanced stage disease, where surgery is not feasible, FNAC or a true cut biopsy can be done. Remember that tumor markers are not important for diagnosis but for prognostication and follow up. In epithelial ovarian tumors, CA125, CA19-9, and HE4 are important. In granulosa cell tumor, inhibin is the marker, while, as I told you earlier, in sex cord stromal tumors, AFP, LDH, and HCG are the tumor markers. Time to stage the tumor now, as per FIGO 2021 staging system. So, stage 1, as always, the tumor is confined to the organ. In here, it is ovary. Stage 2 means it is extended into the pelvis, but it is still below the pelvic brim. 1A means it is limited only to one ovary. 1B means it has gone to both the ovaries, but in both these A and B stages, capsule is still intact. Stage 1C means either one or both the ovaries, that does not matter, are involved, but they have gone outside the ovary also a bit. Like in 1C1, if there is surgical spill, there was no tumor before, but during surgery it spilled outside. C2 means capsule was ruptured even before the surgery. And stage 1C3 means peritoneal washings or the ascitic fluid that you have collected during the surgery has shown malignant cells. By now, you would have learned that stage 3 in almost all gynecological cancer stands for lymph node involvement. Now, lymph node you can remember like globular or circular structures or deposits. So, in ovarian cancer stage 3, it is about peritoneal metastasis, which are outside the pelvis, or the retroperitoneal lymph nodes. Stage 3A means either the lymph nodes in the retroperitoneum are positive, or in the peritoneum there are microscopic deposits present which are less than 1 centimeter in size, mostly confirmed by the histopathology report. Stage 3B means the deposits are of the size between 1 to 2 centimeters, and 3C means they are really big deposits, more than 2 centimeters in size. Stage 4, you all know that it is the stage of distant metastasis. But here is a little twist in it. In ovarian cancer, 4A means positive pleural effusion. Only when the pleural effusion shows malignant cells, it is 4A. 4B means involvement of extra abdominal organs like the brain, bone, or liver. Important point to note here is that even the positive inguinal lymph nodes or other distant lymph nodes like the supraclavicular one makes the disease stage 4B. Ovarian cancer is treated with surgery and chemotherapy. Surgery means hysterectomy with bilateral salpingo ovariotomy, omentectomy, peritoneal washings, and peritoneal biopsies. Lymph node sampling in ovarian cancer is still a topic of debate. Wherever possible, surgery should be done first, which will follow the staging, and then chemotherapy should be given as an adjuvant treatment. However, in those cases which are inoperable, neoadjuvant chemotherapy plays a great role, which is followed by interval debulking, which is followed by adjuvant chemotherapy. To summarize, among all gynecological malignancies, the highest mortality rate is seen with the ovarian cancer. Ovarian cancers present with histological diversity as the ovary arises from pluripotent cells that can differentiate into various tissue types. 90% ovarian cancers are epithelial in origin. Symptoms are nonspecific. Characteristic finding of solid cystic abdominopelvic mass plus ascites clinches the diagnosis. Tumor markers are only of prognostic value and for follow-up. Mainstay of treatment is surgery plus chemotherapy. That's it. Thank you.